today we will discuss about an interesting topic, diabetes insipidus. Right. Now, this diabetes means that increased urination, right? So, diabetes means it is a increased urination. Now, we have came across two terms of diabetes. It may be either the diabetes insipidus or it may be diabetes mellitus. The mellitus, the term, it comes from the term honey, right? That means it is a sweet taste, due to sweet taste. And the insipidus means it is the tasteless. So, tasteless increased urine, it is the diabetes insipidus. Diabetes mellitus, we all know it occurs due to decreased secretion of insulin, or it may be due to the resistance to the insulin action, that means insulin resistance. Whereas the diabetes insipidus, it may be due to the decreased ADH secretion or due to any reason if the ADH unable to act over its receptor. Now, a brief idea about the ADH. For the detailed review of ADH or the vasopressin, you can watch our video, detailed review over the ADH you can find there. You can also find the link at above. Now, this ADH or vasopressin, it is a peptide hormone which is synthesized by the supraoptic and the paraventricular magnocellular neurons, and which are stored at its nerve terminal, which are located at the posterior pituitary. Now, when the proper stimulus for the secretion it comes, the ADH it will be released into the circulation and it will go to the site of action. Where is the site of action? These are the cells over the distal convoluted tubule and the collecting duct of the renal tubule, which are sensitive to the ADH. Now, this ADH, after coming out from the circulation, it will act over the V2 receptors, which is a serpentine 7-pass receptor located at the basolateral side, and by the action it will causes the insertion of the aquaporin 2 channels at the luminal side of these cells. So, the water it can enter inside these cells and it can easily pass through the aquaporin 3 and 4 channels, which are located at the basolateral side, and enter into the circulation. Now, coming to the different causes of this diabetes insipidus. Now, from the discussion above, we have already seen that it may be due to the decreased synthesis or secretion of the ADH, or if the ADH sensitive cell it fails to respond to the normal amount of ADH. Now, if there is decreased synthesis or secretion of ADH, it is called the central diabetes insipidus, and the causes may be genetic causes or the acquired causes. The genetic cause most important is the familial hypothalamic diabetes insipidus, where there is genetic mutation of the arginine vasopressin ABP and neurophysin gene, ultimately resulting in decreased synthesis of the ADH. The acquired cause it involves this part of the hypothalamus or the pituitary, ultimately resulting in decreased synthesis or the secretion of the ADH. Now, from the discussion, it is seen that the central diabetes insipidus, it is occurring due to the decreased ADH synthesis or the secretion. Now, what are the common acquired cause of this central diabetes insipidus? It may be due to head trauma or the surgery involving this part of the central nervous system. The central diabetes insipidus, it may also occur due to the neoplasm, the most important being the craniopharyngioma, which can occur in the young individuals. It can also occur due to the pituitary adenoma. Now, the vascular cause, it involves the Sheehan syndrome. Now, what happens in Sheehan syndrome? It is due to the postpartum hemorrhage which causes the hypotension. That hypotension causes the decreased blood supply to posterior pituitary and ultimately causing the infarction of the pituitary, decreasing the secretion of this ADH. Other cause like the infections like in encephalitis or the meningitis, in which there may be also decreased synthesis of the or secretion of ADH. It may be due to the inflammation of this part of the central nervous system. The next variant of diabetes insipidus is the nephrogenic diabetes insipidus, where the underlying cause lies at the level of renal tubule or the kidney. Now, this nephrogenic diabetes insipidus, it may be again of two varieties, which may be the genetic or it may be the acquired causes. The genetic causes, it is due to the mutation of the gene of the V2 receptors or the aquaporin 2 channel proteins. So, these genetic causes, it may be due to V2 receptor mutation or it may be due to the aquaporin 2 gene mutation. Now, coming to the acquired causes of this nephrogenic diabetes insipidus, and here the most important cause of this acquired nephrogenic diabetes insipidus is the use of different drugs, right? So, the drugs are the most important acquired cause of nephrogenic diabetes insipidus. Now, what are the different drugs that causes the nephrogenic diabetes insipidus? The most important or the most vulnerable drug that can cause the nephrogenic diabetes insipidus is the lithium. Now, the lithium is used in the treatment of bipolar disorder. Next important is the methoxyfluorine, which is used as inhalational anesthesia. Next important drug is the amphotericin B, which is used as an antifungal drug. Cisplatin, it can also cause the nephrogenic diabetes insipidus, which is an anti-cancer drug. Aminoglycosides like the amikacin or kanamycin, these are the nephrotoxic drug, right? And this can cause the nephrogenic diabetes insipidus. Demecoscycline, which is a semisynthetic tetracycline derivatives, it can also cause the nephrogenic diabetes insipidus. Next, other causes of this acquired causes are the next important is the infiltrative cause. In infiltrative causes, there may be infiltration or the deposition of the abnormal amyloid proteins at the renal tubule, causing the damage to the renal tubular epithelial cells. Or it may be due to some vascular causes. The most important of these vascular causes of nephrogenic diabetes insipidus being the sickle cell anemia. Other cause of this diabetes insipidus is the dyspogenic diabetes insipidus involving the thirst mechanism. If we ingest a large amount of water, then what will happen? Ultimately, we will pass increased amount of diluted urine, and if there is dilution or increased in the plasma volume, ultimately it will cause decrease in the ADH secretion. Second important cause, the genetic cause, or if there is any defect in the thirst center of hypothalamus. So, if the thirst center at the hypothalamus, if it is damaged or if there is any defect, there will be abnormal increase in the thirst mechanism. There will be abnormal increase in the thirst mechanism. So, the water intake, it will be also increased and ultimately resulting in passing of increased amount of diluted urine. Another important cause of this diabetes insipidus is the gestational diabetes insipidus occurring during the pregnancy. Now, here the placenta, it synthesizes and secretes two important things. The first important is an enzyme which is known as the vasopressinase. Vasopressinase, Now this vasopressinase enzyme, it breaks down the vasopressin which is present in the circulation. So this vasopressinase, it breaks down the ADH, right? And this placenta, it also synthesizes and secretes different prostaglandins, which causes decreased in the renal sensitivity to the action of ADH. So there will be kind of resistance to the ADH secretion. Now, how to diagnose this diabetes insipidus? Now, in diabetes insipidus, there is decreased action of the ADH, so there will be less reabsorption of water from the DCT and the collecting tubule of the renal tubule, ultimately increasing in the urine volume. That means there will be polyuria. So in polyuria, there is increased total amount of urine, maybe greater than 3 liter in 24 hours. As increased amount of urine it is passing, so it causes the dilution of the urine and decreasing the urine osmolality. As more amount of water it is passing through the urine, there will be plasma concentration. So concentrated plasma it will be there, so it will lead to increased in the plasma osmolality. So urine osmolality it will be low, plasma osmolality it will be high. As there is plasma concentration, or the concentration as the fluid volume inside the blood it is low, there is increased concentration, so it will lead to the increased concentration of the sodium in the plasma, that is the hypernatremia. And this hypernatremia it is secondary to decreased in the blood volume. So as there is decreased blood volume, it leads to relative hypernatremia. As the plasma osmolality it is increased, it will now stimulate the thirst center at the hypothalamus. Ultimately, it will increase the thirst and resulting in polydipsia. So the polydipsia and this polyuria, these two features are similar to as that of the diabetes mellitus, but in diabetes insipidus there will not be any polyphagia, which is the characteristic feature of diabetes mellitus. Also in diabetes mellitus, the urine osmolality it will be high because of the presence of increased amount of glucose in urine. The most appropriate and the investigation of choice for diabetes insipidus is water deprivation test, in which the subject is not allowed to ingest water for a prolonged period of 10 to 12 hours. During this period, the samples of urine are collected and the urine osmolality of those samples are plotted against the time interval graph. In the later phases or towards the end of this test, also we give the patient or the subject desmopressin, which is the synthetic analog of ADH. Now if we look at the graph of a normal person, so when you stop taking the water, body will try to reabsorb more water by increasing the ADH secretion. So the urine osmolality it will increase but reaches its peak around 4 hours. Now after that the urine osmolality does not change and a plateau it is reached, right? Because the ADH induced increased reabsorption of water, it gets saturated. So even if we give the desmopressin in this subject, there will be no change in the urine osmolality, okay, because the ADH induced mechanism it is already saturated. Now if you look at the graph of a central diabetes insipidus patient, so even when we don't take the water, the patient it will excrete the hypoosmolar increased amount of urine. But when we give the desmopressin, it will causes increase in the urine osmolality, as now the desmopressin it will now act over the renal tubular cell to cause the increased amount of water reabsorption. the nephrogenic diabetes insipidus, but when we give the desmopressin there will be no change in the urine osmolality, as the defect in nephrogenic diabetes insipidus, it lies in the defective action of ADH at the renal tubular cells, whereas in the central diabetes insipidus it is due to less ADH secretion. So this yellow colored graph, it is. Now coming to the treatment part of this diabetes insipidus. Now according to the cause of this diabetes insipidus, the two important variant of diabetes insipidus is the central diabetes insipidus and nephrogenic diabetes insipidus. In central diabetes insipidus, there is decreased in the ADH in blood. So the drug of choice here will be the desmopressin, which is the synthetic analog of ADH, right? So the treatment of choice or the drug of choice in central diabetes insipidus is desmopressin. Whereas in nephrogenic diabetes insipidus, by anyhow the ADH is not able to act over the ADH sensitive cells at the distal convoluted tubule and the collecting tubule. Here the treatment of choice, we give the thiazide diuretics. So keep it in mind that in nephrogenic diabetes insipidus we give the patient thiazide diuretics. Now how this thiazide diuretics acts? Basically, initially as it is a diuretics, it increase the urine, it will increase the urine output. So if along with the diabetes insipidus it will increase the urine output, and it will cause the dehydration. Now this dehydration, the body will try to increase the water reabsorption from the proximal tubule. We all know that 65% of the total water reabsorption occurs from the PCT. Now in this case the body will try to reabsorb more amount of water, more than 65% from this proximal convoluted tubule. So in the latter phases the urine output, it will decrease. So whole of this action, that means initially increase urine output and ultimately there will be decreased urine output, it is the paradoxical effect of the thiazide diuretics, and which is the treatment of choice in nephrogenic diabetes insipidus.